Thank you, Mrs. Sarjani, and I have also to thank the organizing committee and Professor Kochis, who I suppose that he is present there. I regret that I'm not there with you with a physical presence. However, I had the chance to visit the beautiful area of Porto Heli very recently, so I chose a virtual background that resembles to the area. I hope this is okay with you. I will go on and share my screen. Okay, so my topic is the use of semaglutide in non-alcoholic steatohepatitis. It resembles with the previous topic. However, we have more robust data about the use of semaglutide in this disease, and it's enough to include this pharmacological agent in the current guidelines, although not not for non-alcoholic steatohepatitis, but for its comorbidities. This is my conflict of interest slide. I divided my lecture in two parts. The first one is rather generic, rather general. I will skip some slides because there must be some overlap with the previous speaker. And of course, the second one is more specific, more focused on the use of semaglutide. This is the disease that we're talking about in this interesting roundtable. The old terminology is NAFLD. I have to state and to point out that is diagnosed either radiologically with MRI-PDFF. This is the the best radiological method to diagnose the disease, or of course histologically. And you have to exclude three different parameters: other liver diseases that can cause liver steatosis, excess alcohol intake, and you can see the range of alcohol intake that we normally see that is harmful for a patient. And of course, you have to exclude long-term treatment with the drugs that can cause liver steatosis. Of course, as Mrs. Theocharidou have already shown to you, and I suppose as it is already known, we have for the second year now a new terminology under the umbrella term steatotic liver disease. That means from the beginning that you have to exclude things. You have to exclude alcohol intake, you have to exclude drugs, as I said in my previous slide, and you have to exclude other diseases. If you have satisfactorily excluded these parameters, then you come with a diagnosis of metabolic dysfunction associated steatotic liver disease, or MASL. This is the acronym that I will use for the rest of my presentation, which is the current name, the current terminology for the disease that we used to call NAFLD. And it is diagnosed if you have steatosis in whatever radiological method you use. A simple ultrasound can fulfill this criteria. And of course, you have 1 out of 5 of the criteria, of the cardiometabolic criteria that, of course, the audience of this Congress is well aware of, and you can see them in the lower part of this slide. Don't forget to exclude things. Don't forget to exclude drugs or other diseases that can cause steatosis. It's a prevalent disease. Recent data show that it's almost 1/3 of the general population all over the world that has MASLD. And of course, it's a disease that has shared risk factors with other cardiovascular disease. So this roundtable is well placed in this Congress. As you can see, of course, this is an old slide using the NAFLD term. MASLD and cardiovascular diseases have shared risk factors, which are either environmental or coming from other comorbidities, as I have already spoke of. Of course, not every patient with MASLD, not every patient from the vast number of patients all over the world that have MASLD are at risk. We have to distinguish which patients are at risk, and this is done by stratifying them along the fibrosis range, which comes from F0, no fibrosis, up to F4, which is cirrhosis. and this is mainly done with non-interventional methods that I will show you in a minute. And this has been already shown by Mrs. Theocharidou, and I will also want to point out that the mortality is correlated with the fibrosis stage, so not only the progression of liver disease, but also the mortality and the cardiovascular disease events can be correlated with the fibrosis stage. So it's crucial to see what is the fibrosis stage, and this is the American Association for the Study of Liver Disease Practice Guideline published last year, stating that the first thing to do for a non-specialist, for a cardiologist maybe, for a primary care physician, for a diabetologist, is to use non-interventional panels, non-interventional simple serological panels like FIB4, as you can see, I hope clearly in this slide, that can distinguish between patients at risk, as I said already, and patients without risk that can be simply followed in the non-specialty outpatient clinic. On the contrary, these patients that have advanced fibrosis along the FIB4 criterion can have to be referred to a special hepatologist care and specialist hepatology center. This is the overview of the treatment, because we are here to discuss treatment, and of course we are here to discuss pharmacological agents. But before going to the pharmacological agents, I have to present to you what is the mainstay for the management of this disease right now, and this is a patient guideline actually published from the European Association for the Study of the Liver, this time 3 years before. It hasn't changed much. I will show by the end of my presentation the new guideline, the scientific guideline. As I already told you, this is a patient guideline, but you can clearly see that the advice to the patients is common, I suppose, for all atherosclerotic patients. Food, we have to stick to the Mediterranean diet. Activity, you can see what is recommended and what you have to avoid. This is the mainstay for the treatment or for the management better of muscle D. And this is not something that we only hope or wish for our patients to follow. It comes with robust and strong data coming now from an old study. As I saw that there was a vivid discussion about the use of liver biopsy in this disease. This is actually a paired biopsy study after a year, no pharmacological intervention, but only dietary counseling. And you can see what are the changes in fibrosis after 1 year, according to the weight loss that patients succeeded. You can clearly see by the right of this slide that if you lose 10 or above percent of your initial body weight, your liver is getting better, the fibrosis is regressed, or at some percentage stabilized. This is a very, very important point to remember when we handle patients with muscle D. Of course, 2024 is a year of a new licensed drug. This is called resmetirom. Resdifra is the brand name in USA. It's not actually right now licensed from EMA, from EMA to use in Europe. It's an agonism of the thyroid beta receptors in the liver. So the rationale is that we have something like an hepatic hypothyroidism. So this drug causes an agonism of these receptors. It's as you can see, for oral use, the company that owns this drug is Madrigal Pharmaceuticals. The indication per the label in the US is for patients with moderate or severe fibrosis. It's interesting to see that there is no need for histology. You can state and diagnose the stage of fibrosis with international methods, as I already told you. It's a simple regimen, one pill once a day, 80 or 100 milligrams according to body weight, no contraindications and no serious adverse events. And this is the primary endpoint, which is NAS resolution with no worsening of fibrosis, or fibrosis improvement by one stage with no worsening of NAFLD activity score. There is a very well conducted program of resmetirom with 3 and more studies that have been published in the New England Journal of Medicine. Mainly, you can clearly see the difference as compared to placebo. Don't be disappointed by the rather small numbers of improvement. If you can, there is another slide that shows that from patients that were treated with resmetirom, about 2/3 of them had some improvement. Of course, this is the primary endpoint. We have to show one stage, at least one stage of improvement in fibrosis. So we have, not us, not in Europe, but in the world, we have for the first time a pharmacological agent that can be used in this disease. But we are here to discuss about semaglutide, which, as you can see in this slide, is currently at a phase 3 study, not by itself. There are many drugs in phase 3 studies and in phase 2b studies as well. But semaglutide has, as I said in the beginning of my talk, robust data already. And I think that this fall, we will have some announcements in the American Association for the Study of the Liver Disease Congress in the US this November that will probably or hopefully give some hope for semaglutide. I will stay in this slide to point out that this is not the only GLP-1 receptor agonist that is used in this disease. You can clearly see that there are 2 other dual agonists, survodutide, pemvidutide, and tirzepatide. So this means that the rationale under the use of semaglutide is strong enough to support 4 drugs in progression in this disease. It's a known drug that has a very complex mode of action that affects many systems and many organs. You can see here the hepatic events that we have with the use of this drug, the decline in endogenous glucose production, the increase in hepatic insulin sensitivity, and the decrease in de novo lipogenesis, lipotoxicity, and steatosis. And of course, it's, I suppose, very well known in this audience that we have documented cardiovascular improvement with the use of these drugs, with a number of well-conducted and published in very well-journal studies that has shown superiority as compared to placebo in the cardiovascular coverage of our patients. Regarding the liver, what is already published is the phase 2b study, which used different dosage. As you can see, the drug was used once a day at a dose of 0.1, 0.2, and 0.4 milligrams. The endpoints were pretty straightforward for this type of studies. Resolution of steatohepatitis, again, with no worsening in liver fibrosis down here. And the patients were patients at risk, with NAS at risk, with fibrosis stage 2 and 3. At the end of the study, there was inclusion of some patients, a minority of patients with fibrosis 1. These are the results. There is a clear benefit with the use of drug, whatever the dose is. As you can clearly see, the better benefit is with the use of the bigger dose, 0.4 milligrams per day. And this is the benefit that we saw in the fibrosis, which is not statistically significant. And this is what we have to point out. All the studies that we will present to you with the use of semaglutide has a clear benefit in the inflammation, in what liver fat can cause in the liver, but not clear benefit in regards to the fibrosis. These were strong enough data to support the evolution of a phase 3 study, which is actually, I will come back to this slide, presented in this slide. Here, the dose that is used is 2.4 once weekly. The dose that is used for obesity, and it's not commercially available, at least in Greece. These studies, the phase 3 studies, have a different design. They are divided in 2 parts. The first part is pretty straightforward. As I already said, we have to show that there is improvement in inflammation and fibrosis. The second part is per FDA's regulations, and the drug has to show that it decreases the hepatic associated outcomes in 3 to 5 years. So these studies are well designed and long-standing, and they have to show that the patients have actually benefit in clinical practice, not only in what the biopsy can show. I go one slide before and show to you this systematic review and meta-analysis showing that semaglutide is included actually in the drugs that have showed benefit in fibrosis improvement and NASH resolution, among other drugs. This is actually, the phase 3 study is actually ongoing, and as I already told you, we expect some results this fall. We have another interesting study for the use of semaglutide in patients with NASH cirrhosis, published last year in Lancet Gastroenterology and Pathology. Again, the pattern is pretty much the same. You can see that there is this was a double-blind phase 2 study, smaller sample, 71 patients. I will try to remember that this is a cirrhosis study. Again, the dose 2.54 milligrams versus placebo for 48 weeks. No difference in the primary outcome for cirrhosis patients. It's very important for fibrosis to be regressed, and this was not succeeded in this study. However, patients that received semaglutide experienced improvement in their cardiometabolic characteristics and decrease in the percentage of liver steatosis as assessed with MRI-PDFF. So it's clear from all the studies of this drug that patients have cardiometabolic benefit. It is shown still if semaglutide actually has some benefit in fibrosis as well. But as Mrs. Theopharido already stated for many times, and as I stated as well, muscle D is a disease with a very complex pathophysiology. You can see in this graph how many pathways and how many substances are included in the pathophysiology. And it makes sense that maybe combination treatments have some better results rather than solo treatments with one pharmacological agent. And semaglutide, it's very important to remember that semaglutide is included in every combination study we have up to now. There are not many, but it's very interesting that semaglutide, possibly due to its very beneficial cardiometabolic act, is included in these regimens, in the combination regimens. So I chose to show you one of these studies, which is a combination study with biopsy for biopsy-proven MASH stage F2 or F3 patients. The drugs that were used is semaglutide in the dose of 2.4 milligrams, along with cilofexor, which is an FXR agonist, and fircocostat, an ACC inhibitor, which is actually an anti-fibrotic agent. The primary endpoint was safety. This was a pilot study, and you can see that the study was positive, meaning that there were not unexpected safety signals. And in addition to that, you can see that patients that received combination treatments showed greater reduction in liver steatosis as assessed radiologically, liver enzymes and non-invasive markers of fibrosis as compared to those that received only semaglutide. This is something to remember for the future. coming to the end of my presentation, and as I already told you, I will present with one slide only the current clinical practice guidelines coming from a joint effort from 3 scientific societies, as you can see, the European Association for the Study of the Liver, the European Association for the Study of Diabetes, the European Association for the Study of Obesity. It's a joint effort. The text has been published this June. And I go straight along to the slide with the management of muscle D, the pharmacological options that we can use right now. And you can see that semaglutide is included, not for the liver. It's only resmetirom there in the left part of the slide, but we can use, and actually it's recommended to use semaglutide if the patient has the comorbidity of type 2 diabetes or obesity. So as I already said, it's my lecture is well placed, and the place of semaglutide is very promising for the future. So, Chair, dear audience, I will come to my conclusion stating that studies with semaglutide in patients with MASH have confirmed its favorable cardiometabolic actions in this subpopulation as well, meaning that it has been already shown in other atherosclerotic disease. Now we have, as I told you for a lot of times, robust data to say that for liver disease as well. It seems that semaglutide so improves at least some features of MASH. The ongoing phase 3 trial will confirm its effect on liver fibrosis and liver-related outcomes with its binary design, and combination regimens with other drugs may have additive effects in patients with MASH, and we will see that in the future, I suppose, as well. Thank you very much.